So far in this chapter, almost all of our focus has been on major depression and other depressive disorders. I now want to switch to bipolar disorder, which at one point was referred to as manic depression because it is characterized by both mania and depression, typically in episodes and typically with fairly long periods of normal mood in between. Bipolar 1 is defined by having at least one manic episode. Note that even though it's called bipolar, you do not have to have a depressive episode. If you have a manic episode, you likely will have depressive episodes, but the manic episode is all that is required for this diagnosis. Bipolar 2 includes at least one major depressive episodes and at least one hypomanic. Remember, hypomanic means less than full manic. Hypo always means less than. So in a hypomanic episode, there's mania, but at a lower level, a more controlled level. Now, you can think of bipolar 1 as, I'm sure this person has bipolar, and bipolar 2 as, I'm pretty sure this person has bipolar, but I'm not positive yet. Typically, most people with bipolar 2 disorder will eventually get bipolar 1 disorder because they will have the defining characteristic, a full manic episode at some point. But we're not confirming that just yet. Just like we had a milder but more persistent version of major depression, which we call dysthymia, now called persistent depressive disorder, we have a milder but more persistent version of bipolar disorder called cyclothymic disorder. Here we have rather dramatic mood fluctuations from hypomanic to depressive, but not nearly as dramatic as what we find in bipolar disorder. But these mood fluctuations move along for a much longer period of time. They're very persistent, very chronic. What is clear is that the genes that are behind bipolar disorder seem to be shared with cyclothymic disorder. So often people who eventually earned the diagnosis of bipolar disorder previously had the diagnosis of cyclothymic disorder. Once again, the manic symptoms characteristic of bipolar disorder, just like the depressive symptoms characteristic of major depression, can result from medications or other physical disorders. So we have diagnostic categories for bipolar disorders that are the result of these processes. What do we know about the causes and contributing factors to bipolar disorders? Genes clearly play a strong role, and there's at least some evidence for several individual genes. It's clear that it's polygenic, that there's not a single gene that is responsible. Whether the genes on chromosome 4 and 12 and 18 and so on are the most important genes or even genes that are consistent contributors is not yet clear. But we're gradually getting sufficient information to help us to determine that. Remember that with both depression and now, with mania as well, the HPA axis is active, and the HPA axis has genetic factors that contribute to it. And in particular, in bipolar disorder, there seems to be a higher output of cortisol when the HPA axis is active. Stress can help to trigger these disorders, just as it can in major depression. And we know that there's a difference between high and low income individuals and countries with high and low income in terms of the risk for bipolar disorder. From a neurochemistry point of view, norepinephrine seems to be prominent in the manic episodes. Remember, norepinephrine was also prominent, along with serotonin, in major depression. The most common treatment for bipolar disorder is a naturally occurring salt, lithium, typically in the form of lithium carbonate. Now, there are newer drugs on the market. There's some research on them, but not a lot. So at this point, I would still say lithium is the most widely used drug. It's not profitable for insurance companies because lithium is a natural salt, very easy to manufacture. There's not much profit to be made. Lithium tends to stabilize mood, which means if the mood's too high, it tends to bring it down. If it's too low, it tends to bring it up. But the problem with lithium is the minimum effective dose is dangerously close to the minimum lethal dose. So you have to be very careful. You have to constantly monitor the level of lithium so that it doesn't get to a potentially lethal level. That's difficult with bipolar disorder because the rate at which lithium leaves the body is affected by the level of manic symptoms. So as the symptoms vary, the amount of lithium that a patient should be taking also has to vary. In lower doses that are nowhere near the lethal dose, lithium can have a prophylactic effect, which means it makes it less likely that a manic episode will develop. So most people with bipolar disorder will continue to take lithium at a lower dose after the manic episode passes. Now, the history of this is also interesting. Just like ECT, at one level it was an accidental discovery, but at another level it's a case study of good science. For many years, we believed that there was a link, possibly a causal link, between uric acid and mania. And the rationale for that is that during manic episodes, the kidneys function at a much lower level. So your bladder fills more slowly. Okay, we now know that's simply a matter of autonomic arousal. When the sympathetic nervous system is active, the kidneys decrease their activity. When parasympathetic nervous system is active, which is certainly not going to be the case during a manic episode, it will increase its activity. But we didn't know that at the time. To test that hypothesis, a scientist named John Cade injected animals with uric acid, expecting that if uric acid was triggering the manic episodes, that you would see the animals kind of go crazy and start bouncing off the wall. And he found exactly the opposite, that they looked, if anything, lethargic. Now, what he reasoned is there was something about the uric acid or other things that were in the injection that was causing this lethargy. Now, uric acid does not dissolve easily in water, which is one reason why they encourage you to drink a lot of water, because it keeps the uric acid that'll be in your bladder, removed by your kidneys, dilute. If it's not dilute, what happens is it tends to crystallize. Those are called kidney stones. They are unbelievably painful. You do not want to go through them. I've been told, I've never had kidney stones, that it's the closest that a male will ever come to understanding how painful childbirth is. At any rate, in order to get lithium to dissolve so that it could be injected in the animals, you needed to have other chemicals that make it more soluble. And one of them turned out to be lithium. And that turned out to be, after several studies, the mechanism that slowed the animals down. So they tried lithium carefully because they knew it was potentially lethal in human beings, and indeed it does work for bipolar disorder. We also have additional drugs, and there are newer drugs on the market as well. Drugs that have been used now for decades include anticonvulsants. Tegretol, Depakote are the two most widely used. What's interesting about these is they will work, often in cases when lithium does not work. So it gives us alternative treatments for people that don't respond well to lithium. If you're wondering what this graph is, that's an EEG. On paper, the way they used to be done. Now they're all done electronically. And what you're seeing in that EEG is a seizure. Normally, each of these lines represent very different activity because the different parts of our brain are doing different things. But when you have a seizure, you have these waves of activity that are coordinated throughout the brain, and that's what you're seeing here. What about psychotherapy for manic episodes? Well, during a manic episode, you can't even talk to a client effectively. You certainly can't do therapy because, well, they're going a mile a minute and they can't focus on anything long enough to do anything. And there's no evidence that psychotherapy reduces the risk for manic episodes. Relapse prevention by focusing on expressed emotion in families shows some promise. Remember, we talked about that with respect to schizophrenia, but at the time we noted that many psychological disorders are affected by expressed emotion in families, and bipolar disorder is similar to that. Now, you're probably wondering why there's a picture here of Charlie Sheen, who, in my estimation, is a brilliant comic talent who has wonderful comedic timing. But he's no longer a part of the show that he made famous called 2.5 Men because he had a very well publicized bipolar disorder, manic episode. Now, in part, it was also fueled by cocaine use during it, but it was a manic episode. He had been subject to such manic episodes, and for the better part of several months, he was on the news every single day for some outrageous thing he did before he was finally fired from the show. What that illustrates is where psychotherapy is important in bipolar disorder. When people are in a manic episode, their behavior is outrageous. Their behavior is often very cruel, even if the individual doesn't have a cruel bone in his or her body. They will say horrible things. And then afterwards, they have to repair those relationships, or at least apologize, which is very difficult when you've basically offended almost everyone you come into contact with. So that's where the psychotherapy tends to be of value. The final topic in this chapter is suicide. Now, it sort of belongs in this chapter because both bipolar disorder and major depression have higher rates of suicide, but there are other disorders that also have high rates of suicide as well. This is as good a place in the textbook to put it, but be aware that it's not related just to depression. Suicide is one of the leading causes of death, and suicide attempts are fairly common. Some accidents may be suicides, and we're not sure. If someone runs off the road and there are no skid marks, no obvious attempts to brake, were they trying to run their car into a deep ditch or canyon? Or did they just fall asleep and didn't wake up until the car was airborne? Often we don't know. One point I want to make is suicide is not that common. Suicide attempts are much more common than actual completed suicides, and suicidal thoughts are actually quite common. Most people with suicidal thoughts never even attempt suicide. Almost everyone who attempts suicide and completes suicide has a history of suicidal thoughts. Certainly, depression increases the risk for suicide, but panic disorder, schizophrenia also significantly increase the risk. In fact, to the same level as major depression. Males are more likely to commit suicide than females, about 3 times more likely. But females attempt suicide about 3 times more often than males. You can do the math there, and you'll discover that the means of attempting suicide among males must be 9 times more lethal than the means that women use. Women traditionally will use things like overdose of medications, where men are far more likely to use things like guns or jumping off of buildings. Once you pull a trigger, you can't pull it back, but once you take some pills, there's a long time where you're still able to reduce the risk of dying. Also, age is a factor, but not in the way you think. Younger children, adolescents primarily, will attempt suicide, but most of their attempts are not terribly lethal. So their suicide attempts can be very high, but only about 0.5% of those attempts end up being lethal. The group at greatest risk are older people, and mostly we're talking about older white males. We believe there are several reasons for that, but the most important is that older white males are more likely to be socially isolated and therefore lack the social support that ethnic minority groups have for both males and females, and women tend to have. This is a complicated slide, so rather than give all the details, let me give you the take-home message. There is some evidence across the board that the rate of suicide is gradually increasing. From 1999 through 2014, there is in many subgroups an increase, a significant increase in the number of suicides. What do we know about suicide? Well, I'd like to tell you we know a lot, but the truth is we really don't. Suicide tends to be very individualistic. Each person who attempts or commits suicide is a little different from other individuals. Often, suicide is associated with a stressful event, but the stress is clearly not the cause. Typically, there are other things going on, but it may be a trigger, or at least a contributing factor. We tend to classify suicides into some general categories. Different books give different levels. Your book talks about 4 kinds of categories. Others talk about 3. I'm going to follow your textbook. Some people commit suicide to get away from an intolerable situation. They'd be, in their mind, better off dead than what they're living through. Some people attempt suicide because they're really angry at other people, and it is the most effective way to get even. It basically is a way of making them feel guilty for causing you to kill yourself. And in many cases, the individual is hoping that they will carry that guilt for the rest of their lives. Sometimes people commit suicide for just the opposite reason. Rather than wanting to hurt people, they want to save people from pain. A person, for example, who's been diagnosed with Alzheimer's may realize that for many years they're going to continue to go downhill and be more and more of a burden to their family. And that, in fact, they may bankrupt the family in the process and seriously hurt others. So their suicide or suicide attempt is a way of saving the family from that. May be true not only of Alzheimer's, but cancer, where, okay, the person has a high probability of dying anyway, but if they last a long time, the medical bills could bankrupt the family. Some suicides, they'll fit into another category. It's basically a challenge to oneself. It's almost a game. It's just a game where you didn't expect to die, but you misjudged. Again, that's a relatively new category. The first three categories have been recognized for 50 years. Risk factors are things that tell us how much we need to worry about suicide with a given individual. Most people who commit suicide have previously attempted suicide. So if they've attempted suicide, their risk of attempting again and maybe being successful is much, much higher. People who have thought of how they will commit suicide and have a method that is legal and that is easily accessible to them are at much higher risk than people who just feel suicidal but haven't thought about how they would do it. Again, we already mentioned males are about 3 times more likely to commit suicide. Hopelessness is the single most important psychological variable in predicting. Even if you're very depressed, but you have hope that you will come out of the depression, your suicidal risk is less. But if you don't have that hope, the risk is much higher. Disorders, we've already talked about them, like mood disorders, schizophrenia are high predictors. And any disorder that has led to a psychiatric hospitalization is a very good predictor of risk. Alcohol and drugs are often involved in suicides, but they don't really seem to be the cause or a contributing factor. Many people use terms like liquid courage to describe the use of a drink or two, and usually it's only a drink or two, prior to a suicide attempt in someone who's been suicidal for some time. Also, chronic health problems, especially if they're potentially terminally ill, or alternatively are looking forward to a lifetime of serious health problems, are a risk factor. Can we prevent suicide? The short answer is no. There will always be some people who commit suicide. Can we reduce the risk? The short answer is probably. Generally speaking, the more family support and support from friends and colleagues, the less likely someone is to commit suicide. The more likely that the person is employed and has plans for the future, and therefore some hope, the less likely they are to attempt suicide or commit suicide. Suicidal ideation can be around for a long period of time, but the suicide effort itself is often very impulsive. So anything that you can do to reduce the likelihood of an impulsive act that leads to a lethal consequence can help. Some of our efforts with community mental health services have been focused on the idea that the way to prevent suicide is to simply treat in the community emotional problems as they develop and before they develop to the point that they trigger high levels of suicidal ideation. One preventative strategy is the crisis hotlines. They've been around for decades. They are very low cost. Often they are in storefronts in relatively low cost areas. In many cases, their therapists, if you want to call them that, are volunteers from the community who've been trained in exchange for agreeing to serve on these hotlines for a limited period of time. Although in many cases, the people who are on these are involved in these programs continue to do it for years. What happens is someone who's feeling suicidal or just needs to talk calls a number. Now, for many years that number was a local number, but these days the number could be almost anywhere. And there's someone there to answer the phone and to listen to them and to ask them questions. Usually that person is not trying to do therapy, but rather just trying to provide support. Remember, social support makes everything better. And hopelessness, which is very important when we're talking about suicide, is not likely to occur if you feel you have any sort of social support. Now, many people call crisis hotlines not because they're immediately suicidal, they're just very lonely. And if it's a slow night, the individuals are more than happy to talk with those individuals. There are regulars that call in all the time. And there are people that are imminently suicidal that call in as well. And in some cases, there may be people that are calling in that don't need to call in, but they do. If someone talks about suicide, the individual at the Crisis Hotline Center will try to assess the lethality and determine what steps are there. Now, there's a variety of ways of assessing lethality. If, for example, the individual has a means in mind, they're going to shoot themselves, their lethality is higher than if they haven't thought about how they would commit suicide. If they want to shoot themselves but they don't own a gun, well, they're going to have to go out and buy one and buy bullets and learn enough about the gun to be able to operate it. So their lethality will be lower than someone who does own a gun and has bullets and could, remember it's an impulsive act, could simply say, I can't take it anymore, go to the closet, get the gun, put some bullets in, and a minute later be dead. Again, you try to assess how imminently dangerous it is and then deal with it. Now, there are several processes that have been shown to be effective. For example, if they are thinking of killing themselves by shooting themselves and they have a gun, perhaps you can get them to realize it would be in their best interest to not have the gun in the house. Perhaps they can give it to a family member or a friend to hold for a while. They don't have to tell them exactly why, just get it out of the house. That means that they can't commit suicide impulsively. They will have to take several steps over a prolonged period of time, and therefore they'll have many opportunities to say, I'm not sure I really want to do this. One thing that is remarkably effective that logically shouldn't work at all is telling the person, look, I understand you're suicidal, and I understand there's reasons why you're suicidal. And I'm not going to try to control your life, but in my experience, suicide wipes out any chance of dealing with the problems that you right now feel you can't deal with, but I'm quite sure you can. So I believe that if you can get through this period, there's future hope for you. But if you want to kill yourself, can I ask a favor? Can I ask that you call me first? Ask for me specifically. We'll talk about it. And if you decide you still want to kill yourself, that's your decision. Now think about it. Why would they call you if they want to die? But in many cases, most cases, they do call. Which means there's a piece of them that probably is still ambivalent about dying. But there's another thing there. Those few short words are basically saying, I'm here for you. They're providing a social support contact. Remember, social support doesn't cure things, but it makes things better. And it probably makes the situation less hopeless because there's at least one person who seems to care. It works, and it's often used by therapists everywhere who have suicidal clients, especially therapists who deal with that in crisis hotlines. The thing about crisis hotlines is it's not really clear if they reach the right people, how big an effect they have, but they'll probably continue because they're a very low cost compared to other mental health services intervention. And even if their effect is modest, it's still cost effective. So in this chapter, we covered primarily 2 mood disorders. Depressive disorders, there are several variations of it in bipolar disorder. And we talked a bit about the causes and the treatments available. We also talked about suicide, which is related to mood disorders, but not just mood disorders. Suicide is found in several psychological disorders as well.